morning, Chairman, ladies and gentlemen. First of all, I would like to thank the organizing committee, especially Dr. Mahan, for giving me this chance to share my experience with you. In the following 15 minutes, I will first give a brief introduction of the topic, followed by sharing of 3 cases which illustrate the benefits of integrated approach from the pre to postnatal management of congenital heart disease. Congenital heart disease can now be accurately diagnosed before birth by fetal echocardiography from 18 to 22 weeks of gestation. The purpose of fetal echocardiography is to obtain early diagnosis to facilitate early planning of management and intervention, and to help setting priority between mother and fetus in case decision concerning the timing and mode of delivery is needed. Most congenital heart disease can be treated or at least palliated. In some cases, early diagnosis of fetal heart abnormality may be the end of the story because the parents elected to terminate the pregnancy. But in most cases, it is just the beginning for the medical and surgical teams and the family to embark on a long and winding road. So, namely screening and antenatal counseling of the heart disease, regular monitoring before birth, stabilization and postnatal treatments, and a long-term follow-up. Many professionals are involved in the management of congenital heart diseases. If they can work together and form teams for the prenatal and postnatal management, the outcome of patients, especially those with severe congenital heart disease, can be better improved. And in my center, it is a public tertiary referral center. We have obstetric unit, neonatal ICU, pediatric cardiac team. Our cardiothoracic surgeons are operating but on older children only. So if we have severe neonates with severe problem, we need to refer them to the university unit. Actually, we have a close liaison with them, with the obstetricians and also with the university units. For the first case, this was referred at 22 weeks of gestation for fetal congenital heart disease. And you can see that. So this is the left side of the fetus, the right side of the fetus, the spine, aorta is on the right, and stomach is on the right as well. And you can see a dilated ventricle and a smallish ventricle here, and a common AV valve, and the 2 atria with a large primary ASD, and we cannot clearly see pulmonary veins going back to the atria. And moderate AV valve regurgitation. Double outlets from this main ventricle, which is later found to be right ventricle, narrowed ascending aorta and large pulmonary artery. And the fetus is moving, but you can see the aortic arch is narrowed. Coarctation of the aorta here. So the diagnosis was heterotaxis syndrome, dextrocardia, common AV valve, hypoplastic LV, and double outlet right ventricle, coarctation of aorta, and probably supracardiac total anomalous pulmonary venous drainage. So antenatal counseling was given to the parents. The detailed explanation of the lesion and treatment plan was given. Long-term outlook, epidemiology and genetics, and the queries of parents were answered. Psychological support was given to the parents. And we discussed with the obstetricians. So pictures of children with heart disease pre and post-operation were also shown to the parents, so that this is to reassure them the babies after birth will not look very abnormal. So we discussed with the obstetricians and the neonatologists in our perinatal meeting. So plan of management was formulated, and since the fetus can be quite well, so the pregnancy can be carried on until term, and pediatric standby during delivery was arranged, and cardiologists are ready to do assessment and stabilization soon after birth. So the baby was born in 37 weeks, born quite well with normal birth weight and normal Apgar score. He was cyanotic with a saturation of 81%, and chest X-ray and abdominal X-ray confirms dextrocardia, central liver. The stomach is on the right side with the Rouse tip here, but he's quite well. And usually also echo confirmed the diagnosis. Single large ventricle, double outlet right ventricle, coarctation of aorta, and total anomalous pulmonary venous return to the innominate vein supracardiac type. So for these cases, usually it was discovered at around 3 to 4 days when the duct is closed if there is no prenatal diagnosis. But we diagnose it early before birth, so we can see the baby on the first day of life, so that we can refer this patient to the University Neonatal Cardiac Center. And since we want to have a smooth transfer, we do not need to give prostaglandin because the ductus is still wide open just after birth to avoid apnea during transfer and requirement of ventilator. So after transfer on day 2, operation was done for him and resection of coarctation and end-to-end anastomosis, ligation of ductus, PA band to decrease heart failure. And the baby did well, and on day 29, total repair of the total anomalous pulmonary venous drainage was done, and adjustment of the pulmonary band. So the progress was periodically conveyed to us from the university hospital, and we can also get the details of this patient's after transfer from the electronic patient record of our clinical management system of the hospital authority. So we can look at the discharge summary, the OT notes, any laboratory tests, imaging, and any drugs. So we're well informed of the progress of the patient, and this is the patient day 10 after operation. He did quite well. Second case was referred at 36 weeks of gestation for cardiomegaly, fetal cardiomegaly. There was a normal scan at 20 weeks of gestation. So this is the fetal echo. You can see a dilated LV with poor contractility, but the apex of the LV is not reaching the apex of the heart, and the mitral valves look a bit small, and both mitral and tricuspid regurgitation. Poor LV function, and fractional shortening was only 11. So this is to show mitral regurgitation. And you can see this is LA and RA, and this is the atrial septum. We can't see the foramen ovale, and we can't see any shunts between the LA and RA. Dilated pulmonary artery, and also smallish ascending aorta. And the aortic valve seems thickened and not opening. And it measured 5.6 millimeter in diameter. And you can see moderate aortic regurgitation and no forward flow through the aortic valve, and just retrograde flow from the ductus into the ascending aorta. And hypoplastic transverse arch as well. The descending aorta was normal. So the diagnosis was grossly dilated left heart with poor function, left outflow tract obstruction, and possibly a smallish mitral valve, mitral regurgitation, hypoplastic ascending aorta and arch, and premature closure of the patent foramen ovale. So we explained the condition to the parents, and early delivery was needed, and we would try to salvage the baby, but the prognosis was guarded due to the poor contractility. So we discussed with the obstetricians and the neonatologists as well. So one day afterwards, the baby was delivered by cesarean section. He was born cyanotic with a saturation of only 60%, and he was intubated, and we assessed him immediately after birth. And we found the same thing. Now we can see just a very narrow jet of LA to RA shunts, and severe mitral regurgitation, very impaired left ventricular function, also smallish ascending aorta, not much forward flow into the ascending aorta, little bits of aortic regurgitation, not much forward flow through the mitral valve to the LV, and very restrictive PFO. Large ductus, no coarctation. So the hemodynamics is a severe LV outflow obstruction with restrictive atrial mixing. So this is a totally ductal-dependent systemic circulation. You can see the systemic blood return from the systemic veins into the right side of the heart and goes through the pulmonary artery. Part of it goes to the lungs, and the other part goes to the descending aorta and also the ascending aorta. But the pulmonary venous return cannot come back to the left side of the heart. So with this physiology, the baby cannot survive long. So we decided to put in, to enlarge the atrial communication, to do balloon atrial septostomy. Since this baby is only day 1, so it is easy to have vascular access. The umbilical vein is still open. So we did balloon atrial septostomy in the neonatal ICU under echocardiographic guidance. So the balloon was put into the LA from the RA, restrictive PFO, and you can see the baby developed supraventricular tachycardia during the procedure. and it was successfully aborted by adenosine intravenously. So this shows the atrial septostomy. Okay, communication was created. So large atrial communication with good flow, good mixing now. So after the balloon atrial septostomy, saturation improved immediately to the 90s, and the hemodynamics also improved. So we referred this patient to our neonatal surgical center, and because the LV function was so poor, operation was initially not offered to the baby. However, the LV function improved gradually, and there was forward flow through the aortic valve, and it was also shown that the aortic valve opens and closed after around 2 weeks. So in view of severe heart failure at that time, the large ductus was ligated, and the baby did quite well afterwards. So this baby may be having a functional type of left ventricular outflow tract obstruction due to premature closure of the patent foramen ovale, or maybe a form-fruit hypoplastic left heart syndrome. We're still not very sure. So the baby was transferred back to us. His left ventricular contractility slowly improving. Right ventricular contractility was normal. Now this is the baby at present. So for case 3, and this baby our neonatologist was consulted after birth to see this baby because this baby has severe hydrops fetalis. The mother is a tourist coming from mainland China. She has no antenatal follow-up in Hong Kong. And from history, she said that obstetricians in China mentioned to her that the baby has tachycardia, but no treatment was given. And she just came to Hong Kong for shopping, but she was in labor, and then she attended our emergency department. So you can see this baby was grossly edematous, and she was flaccid and blue. Heart rate was only 60, very poor adequate score, 4 at 1 minute and 5 at 1 minute. Body weight was increased. Hemoglobin was normal, so this excluded hematological cause of hydrops fetalis. So we are consulted to look for any cardiological cause for hydrops fetalis. So swollen genitalia, and the whole body was swollen, and you can see a depression was left behind after echocardiogram was done. And chest X-ray showed severe pleural effusion, cardiomegaly, ascites, and echo also showed pleural effusion, severe ascites, and very poor LV contractility as well, and also pulmonary hypertension as determined from the gradient across the ductal flow. And later we noted that this patient developed recurrent tachyarrhythmia, and up to the 240 per minute. So this was aborted by repeated intravenous adenosine treatment. So as the baby was in very poor shape, she was given inotropic support, diuretics intravenously, and anti-arrhythmic drugs intravenously, namely imidodron, digoxin, and because of severe pulmonary hypertension, we also need to give this baby nitric oxide for 2 days. The baby gradually improved, and the hemodynamics improved from desaturation 81% to 100%, a low blood pressure from 39/32 to 74/54 in a few days. And 4 days later, the edema had subsided a lot, and LV contractility has improved a lot, up to normal now, 34.2% for the fractional shortening. And you can see 2 weeks later, the baby was extubated, looked very normal, very cute, and we can tail off amiodarone and change it to oral sotalol. And the ears has markedly improved, the face also improved. In fact, fetal tachycardia can be managed antenatally, and if this was detected before birth, we actually have a plan of management for the different types of tachyarrhythmia. So if there is severe involvement of the baby, mother can be given antiarrhythmic drugs, and if hydrops fetalis is severe, urgent cesarean section to deliver the baby is needed. So in the conclusion, I have illustrated 3 cases on the benefits of integration of care. In the first case, prenatal diagnosis and integrated care bring about smooth inter-hospital transfer and good surgical outcome and early treatment. In case 2, the ones with dilated left heart, prenatal diagnosis just after birth and integrated care enable the baby to survive from an otherwise fatal condition. If there was no prenatal diagnosis, we would not have known that this baby has such poor cardiac problem, and time may be wasted before this can be came to our notice. and so we may not be able to do intervention to help the baby to survive. And for case 3, it illustrated that there were no antenatal diagnosis and no integrated plan of care brings about a stormy neonatal course, and luckily this baby survived. So as technology advances with increased specialization, specialists tend to work in silos. I think it is time for professionals of the various disciplines involved in the management of congenital heart disease to work towards integration of their expertise and management with a view to improve the care and outcomes of these babies. Thank you for your attention, and welcome to Hong Kong, and this is our beautiful Victoria Harbour.